patient for the diagnosis of respiratory diseases. Without taking the history or without going for the laboratory investigations, how can we diagnose a respiratory disease? Okay, just by looking on the patient, just by doing the physical examination of the patient, how can we diagnose a patient having a respiratory disease and what can be a possible respiratory disease? Okay. So what are the clinical findings of respiratory diseases? What are the signs of respiratory diseases? That we are going to see. Okay. And then you have to correlate these findings with your history that you have taken, compare both and then come to a diagnosis. Okay. But if a patient is mentally retarded, or suppose if a patient is suffering from dementia, or if the patient is suffering from some kind of psychiatric illness like schizophrenia, etc., if the patient is unconscious, where he is unable to tell you the symptoms, if the patient is a child, infant, where he is unable to tell you the symptoms, just by looking on him or her, how can you diagnose? Okay. What are the possible things that you can go for and then you can diagnose a disease? So that will be our topic of discussion. Okay. So we have many signs of respiratory diseases. Let us start one by one. The first thing that you have to do is you have to see the patient, inspect the patient for various things. We will start with the basics. First of all, you have to see for the shape of the chest wall. Okay. The shape of chest wall can get distorted in various respiratory diseases, or abnormal shape of the chest wall can also result into different respiratory symptoms. Okay. Both are possibilities. Say for example, if a patient is suffering from COPD, his chest wall will be barrel shape. But if the patient is having kyphosis, scoliosis, or pectus excavatum, that is funnel shape or pigeon shaped chest, then again it is going to affect the respiratory functions of the patient. Okay. So how to see for it? The first point is examination for the shape of chest wall. So what you have to do is you have to see for the chest wall of the patient. You can see for the vertebral column of the patient. Okay. And you have to see for any excessive curvature on the thoracic vertebral spine, thoracic vertebral column. Okay. If there is excessive curvature is present on the thoracic vertebral column, that is called as kyphosis. Okay. See for any excessive curvature on the thoracic column, thoracic vertebral column. Excessive curvature, kyphosis. Okay. Similarly, any S-shaped deformity of the vertebral column, it is scoliosis. Okay. Both of these deformities of the vertebral column, they are going to affect the respiratory functions. Why? Because these deformities changes the diameter of the thoracic cage. In a normal healthy individual, the transverse diameter of the thoracic cage, it is more than that of the antero-posterior diameter. Okay, the transverse diameter, it is more than that of antero-posterior diameter. But if the patient is having kyphosis, the antero-posterior diameter increases, which affects the respiratory functions, the expansion capacity of the lungs. Okay, so it changes that capacity, that respiratory function. Okay, so C for vertebral column, C for kyphosis and scoliosis. If it is absent, well and good, then you have to go for the examination of the chest. Okay, from the front side, here we have seen the back, now we will be looking at the chest wall. Okay, look arm for the shirt. And you have to see for any abnormality in the sternum. Okay, if there is presence of any depression at this portion, it gives a funnel-like appearance of the chest wall. Okay, depression at the lower border of the sternum, it gives a funnel-like depression, which is called as funnel-shaped chest. So what is going to happen in this is funnel-shaped chest, the antero-posterior diameter will even reduce than what is normal. Okay, again affecting the respiratory functions. This happens in various congenital abnormalities. One of them is dextrocardia. Okay. Similarly, if the sternum gets protruded, okay, if the sternum gets protruded, then the rib cage will also get protruded. Okay, this protrusion of the chest wall will be called as pigeon-shaped chest. Again, it will increase the antero-posterior diameter, affecting the respiratory function. Okay, so you have to see for funnel-shaped depressions or pigeon-shaped protrusions of the chest wall. Okay. The next point is, when you are examining the chest wall, you have to see for any scar marks present on the chest wall. Any scar marks on the chest wall. If the scar mark is present centrally, it is called as thoracotomy scar mark. And the chest wall is opened from this side in order to perform the surgeries on the heart. Okay, so if a patient is undergoing for CABG, coronary artery bypass grafting, or open heart surgeries like valve replacement surgeries, in that we perform thoracotomy. We open the thoracic cage from the center and then we perform the open heart surgery. Okay. The second type of scar mark can be seen laterally. Okay, laterally, which is called as lobectomy scar mark, and that is performed to remove any tumor in the lungs, any lobe of lungs, any tumor or any mass, whatever. If you want to perform any surgery on the lungs, we perform lobectomy surgery and then remove that portion. Okay, so it is present laterally. So on the chest wall we get two different types of scar marks. The first one is thoracotomy, which is at the center, and the second one is laterally, which is called as lobectomy scar mark. Right? So when you are looking at the chest wall for the scar marks, you also have to see for any enlargement or any swellings, especially at the supraclavicular region. You have to see for any swellings in the axillary region. You have to see for any swelling in the cervical region. Okay, this portion, which is called as submandibular region, supraclavicular region, and axillary region. Why you are going to examine this portion? In order to rule out the lymph node enlargements. This lymph node enlargement can be because of two different reasons. Infections of the respiratory tract can result into lymph node enlargement, or it can be a malignancy which can transfer to the lymph nodes. Okay, infection can spread to the lymph node, or malignant cells can also spread to the lymph nodes. Right? So lymph node enlargement gives you the idea for two different things: infections and malignancies. Right? So see for lymph node enlargements. If they are absent, well and good. So for this patient, we do not have any skeletal deformity, we do not have any lymph node enlargement. So that means this patient probably is not having any respiratory disease, but we have to go again for other findings to conclude that this is not having any respiratory disease. Right? So till now we discussed two findings. The first one was shape of the chest wall, and the second one was the scar mark, and the third one was lymph node enlargement. Okay. The fourth thing is you have to see for any visible veins at the neck region. Visible and prominent veins in the neck region. If they are enlarged, if they are prominent, first of all, the name of that vein is jugular vein. Okay, and this jugular vein, it directly opens up into the superior vena cava, and superior vena cava opens up into the right atrium, which further opens into right ventricle, and from right ventricle the pulmonary artery originates. So this jugular vein can enlarge under various conditions. Say for example, if a patient is having right ventricular failure, the pressure will increase in the right atrium, will result into enlargement and prominence of
Jugular
the
vein.
jugular vein, right? Similarly, if the patient is having pulmonary arterial hypertension, okay, as the right ventricle is draining the blood into the pulmonary artery, if the patient is having pulmonary arterial hypertension, once again it is going to affect the jugular vein and the vein will become prominent. So you have to see for the enlargement or the prominent jugular vein in the neck region. If it is enlarged, it indicates the patient is having disease related to the right side of the heart. And the diseases of the right side of heart which occurs as a result of disease of the lungs is called as cor pulmonale. The clinical term for those diseases is cor pulmonale. The patient do not have any disease of the heart itself, but his function is compensated. The function of the heart is getting compromised on account of the disease of lungs, right? So that is why it is cor and pulmonale, disease of heart on account of disease of lungs. Okay, so severe fibrosis in the lungs, accumulation of the fluid in the lungs, pulmonary arterial hypertension, pulmonary thrombosis, pulmonary embolism, all of those diseases are the diseases of lungs or the vessels supplying the lungs. But what it is compromising, what those diseases are compromising, they are compromising the function of right side of the heart. That is why it is cor pulmonale. Understood? So the fourth sign is C for dilated tortuous blood vessels on the neck region. If they are visible, it is jugular vein, and jugular vein enlarges because of the right-sided heart diseases. Understood? So that is your another sign of respiratory disease. One more sign of respiratory disease is you have to see for movement of the chest wall. Okay, till now you have seen for the shape of the chest wall, you have seen for the scar marks, any enlargements, any blood vessels on the chest wall. Then next you have to go for movements of the chest wall. Okay. Now if the breathing is forceful, the chest wall can move. You can see the movement of the chest wall by your eyes. But if the patient is breathing in very shallow, very slowly, okay, if the respiration is very shallow, where the chest wall is not moving, many of the times you will not be able to see the movements of the chest wall. Okay, so for that what you do is you have to place your hands on the chest wall of the person, and then you have to feel the movements of the chest wall. Okay, and then you have to compare the movement of chest wall on both of your hands, right? So for that what I am going to do is what we are going to do is, first there are two techniques for it. I am going to place my hands from the front and the thumbs touching at the sternum like this, and I am going to ask the patient to breathe in deeply. ઊંડું શ્વાસ લો કાકા. શ્વાસ લો. And then I have to feel for movements of the chest wall and whether I can feel the movement on both of my hands or not. Okay, this is first technique. The second technique is I will place my hands laterally and again ask the patient to breathe in deeply. Okay, and again I have to feel for the movements on both of my hands, and what I am going to do is I am going to compare whether it is equal on both sides or not. If it is equal, then it is called as air entry bilaterally equal. Okay, if I am able to feel the movement on both hands, well and good. Okay, if on any side the movement gets restricted, say for example I can feel the movement on my left hand, but the movement is absent on the right hand, and this right hand is placed on the left side of the chest wall. That means the patient is having some disease related to the left side, left lung. So it can be the disease of the left lung, it can be the pleura, or it can be the bronchus, left bronchus which is entering. Okay, so it can be any obstruction in the left bronchus, it can be any fluid accumulation, any solidification in the lung parenchyma, or it can be collection of fluid in the pleura or inflammation of the pleura. Understood? So this is the next sign. You have to feel for the movements of the chest wall, and that you can do by two methods: by placing your hands like this at the center and feeling the movement, or you can keep it laterally and then you can feel the movements. Understood? So that is about the chest wall inspection. Next, you have to see for the face. By the examination of the face, you can again diagnose different respiratory diseases. Say for example, if the patient is breathing in through mouth, okay, that means the patient is in respiratory distress. Okay, that is why he is breathing through mouth. Okay, or he can simply open up the lips and he will be breathing in through those pursed lips. That is called as pursing of the lips. Slight opening of the lips and the patient is breathing through it. Okay, this is pursing of the lips and breathing in through it. In this patient, the nostrils will be dilated. Okay, the dilatation of the nostrils, breathing through the pursed lips, using of the sternocleidomastoid muscles for respiration, then using of intercostal muscles for the respiration. All of this indicates that the patient is in respiratory distress. Okay, the patient is dyspneic. Okay, in such a patient you will note that the respiratory rate is also increased. Okay, so you have to see for any use of accessory muscles, breathing through mouth, dilatation of nostrils, and you have to see for the respiratory rate. If it is increased, then the patient is tachypneic. Okay, which again indicates a respiratory disease, and tachypnea is a sign of many diseases. Okay, many respiratory diseases like COPD, bronchial asthma, allergies. Okay, so it can be a sign of different respiratory diseases, right? Now, one more thing that you have to note is whether the respiration is symmetrical or asymmetrical. Okay, symmetrical means a phase of inspiration is followed by a phase of expiration, which is followed by again a phase of inspiration and expiration. So if all these phases are synchronous, inspiration followed by expiration, inspiration, expiration, then we call that respiration as symmetrical. Okay, same, the depth of inspiration and the expiration is also equal. Okay, if you found any abnormalities in it, a phase of deep inspiration followed by multiple small expirations, okay, then it is abnormal. That is indication of Cheyne-Stokes breathing. Okay, and which is diagnosis of different metabolic diseases, like in cases of acidosis the patient will have Cheyne-Stokes breathing. Okay, so you have to see for asymmetry of the respiration also. So the respiration must have to be bilaterally equal, it must have to be symmetrical. Then we can call that is a normal respiration. Understood? One more symptom, one more sign that you can notice is tracheal tug. Tracheal tug. What is tracheal tug? When the patient breathes in deeply, the trachea, this portion, it gets inward, it gets what we say is the trachea gets contracted or it gets अंदर की तरफ खींच लेता है. Okay, you will see that depression more prominently. Okay, when the patient is in severe distress, there is tracheal tug. Okay, when the patient is breathing, you can see the depression becoming more prominent over here. Okay, that is tracheal tug. TUG, tracheal tug. Okay, so this patient is not having tracheal tug. His respiratory rate is normal. The respiration is equal on both sides. The respiration is symmetrical. The patient is not having any skeletal deformity. The patient is not having any scar mark. The patient is not having any enlargement of the lymph nodes. Okay, so that we can say that this patient probably is not having any respiratory disease. But still, we have to go for some more signs and symptoms. Okay. Next sign that can be seen is cyanosis, that is bluish discoloration of the skin and mucous membrane. So we are going to see for the palms, we are going to see for the nails, we are going to see for the lips, we are going to see for the sclera, conjunctiva, bilaterally, and we are going to see for the tongue. Modu kholo, jib bahar kado, and we are going to see for whether any bluish discoloration is present on the tongues. Okay, so if there is any bluish discoloration, it is cyanosis. If it is present on the face, it is central cyanosis. If it is on the extremities, it is peripheral cyanosis. Cyanosis is also a sign of respiratory diseases. Understood? There is one more sign of respiratory disease that you can see for in a patient is clubbing of the fingers. Okay. Clubbing of fingers is commonly seen in cases of carcinomas, bronchogenic carcinomas. Okay. It can also be seen in cirrhosis of liver, but as far as respiratory diseases is concerned, it is bronchogenic carcinoma. Right? So for clubbing of the fingers, what you have to do is kaka khali M karo, am karo, am. That's it. Okay, and you have to see for that small pear-shaped opening in between the nails that is present. Okay, you can see a beam of light passing through it. That means the clubbing is absent. Understood? Picture. So clubbing is absent. That means again the patient is not having any respiratory disease. Understood? So here you have completed the inspection and palpation of the patient in which different signs were absent. Then you can proceed to the next step, which is called as percussion of the chest wall. Basically, percussion of the chest wall is performed in order to rule out any solidification in the lung parenchyma. Okay, lungs are air-filled bags. Okay, it is full of air. So wherever you percuss on the lungs, you will get a resonant sound, because when you percuss, you are displacing the air below your finger. So the sound that will be produced will be resonant. But as soon as that air gets replaced with any solid, consolidation or any fluid, you will get dull note on percussion. So percussion helps you in diagnosis of consolidations and in diagnosis of fluid accumulations, which is called as pleural effusion. It can be hemothorax also. Okay? And suppose if I am getting a resonant note on the right side and I am getting a dull note on the left side of the chest wall, that means the patient is having some disease on the left side of the chest wall. It can be pneumonia, it can be pleural effusion, or it can be hemothorax. And if if the patient is having this disease, then definitely the movements on the left side of the chest will be restricted. The patient will be dyspneic, the patient will be coughing, the patient will be expectorating. Okay, so the symptoms will be there, definitely. Okay. So you have to go for percussion in order to rule out consolidations and pleural effusions. Understood? Once percussion can also be done in order to rule out or in order to differentiate the border of heart from the border of lungs. Okay, but that needs skill, as lungs are air filled and heart is completely filled with blood all the time. When you percuss on the precordium, that is the area of the chest wall just in front of the heart, that is why it is precordium, area of the chest wall which is present just in front of the heart. When you percuss on the precordium, you will get dull note, because the heart, it is always filled with blood. Okay, so say for example this much is the shape of heart. When I percuss on the precordium, I am getting dull note, and as soon as I shift from this heart to the lungs, I will get resonant note, because the lungs are filled with air. Okay, so I can simply tap, go on tapping on the different areas. Wherever I am getting a dull note, that means it is the portion of heart. Okay, where I am getting the resonant note, that is the portion of lungs. Okay, so this percussion also helps in identifying the borders or differentiating the borders of heart from that of lungs. Okay, and by that you you can diagnose whether the patient is having cardiomegaly or not. Okay? But this technique is not used anymore. In cases of cardiomegaly, the patient's apex beat gets shifted. Okay? When we will discuss cardiovascular system, in that I will tell you what is apex beat and etc. Okay? So for now, just remember percussion has two objectives. The first objective is diagnosis of consolidation and pleural effusion, and the second objective is, if you want, you can differentiate between the border of heart and the border of lungs, right? So once you are done with this percussion part, the last and the most important portion of your respiratory examination is auscultation. Okay? So for auscultation you need a stethoscope. Give me a stethoscope. Okay. So for auscultation, we are going to auscultate the three different lung fields: anterior lung field, posterior lung field, and lateral lung fields. Okay. It is preferable to auscultate on the posterior lung fields. Okay. Because as a beginner, many of the times you cannot differentiate between the heart sounds and respiratory sounds. Okay. On the anterior chest wall, you also listen to the heart sounds. It becomes difficult for a beginner how to differentiate between heart and lung sounds. So for a beginner, prefer the posterior lung field and then proceed to the lateral lung field. Okay. So here, the way in which you move your stethoscope, it is very important. Okay. Because we are going to auscultate the lung field in order to do multiple things. We want to know whether the air is entering inside the chest wall or not. Say for example, a patient having obstruction in the trachea, okay, or larynx, there will be complete absence of entry of air on the both sides, right? What we are going to see for is, we are going to see for whether the air is entering on both sides of the lungs or not. Okay, so that is our first objective. Second objective, equal amount of air is getting entered on both the sides or not. Okay. The third objective is, are we listening to any abnormal respiratory sounds apart from normal respiratory sounds? Okay. So, air entering into the tubes, okay, like bronchus, trachea, bronchus major, bronchus minor, bronchioles, etc. When the air enters into these tubes, the turbulent sound is produced, okay, because of that passage of the air. But as soon as this tube gets blocked, okay, you get additional respiratory sounds. Okay. So normally only you can see the entry of air and exit of the air in normal healthy individuals. Okay. But apart from that, if any other sound is getting auscultated, then it is abnormal respiratory sound or additional respiratory sound. So the third objective is identifying any additional respiratory sounds. Okay. So we have multiple objectives. The first one was, is the air entering? Is equal amount of air entering on both the sides? And are any additional respiratory sounds present? Okay. And we have to compare, then the fourth objective is, we have to compare it on both sides. If the additional respiratory sound is present on right side and present on left side as well, or if the additional respiratory sound is present only on the right side and absent on the left side. So it helps you to diagnose that particular disease, whether the sound is on the right side only, so that means the patient is having disease related to the right side of the lungs. Okay. So we have multiple objectives for auscultation. So that is why when you are auscultating, you must have to keep your diaphragm of the stethoscope on any side that you want, prefer right side, upper lobe, and then compare on the left side upper lobe. Okay. And you have to see for all those things: entry of the air, whether it is present on both sides, then you have to see for how much air is getting entered, okay, and whether any additional sound is present on these lobes. If they are absent on both the lobes, well and good. So you have finished the examination of upper lobe. Then you can simply go to the next portion. Okay. Now you are auscultating on left side, or maybe you can go to the right side. Again, auscultate over here, see for these three things again. Then move to the left side, again see for these three things. Okay, if not present, well and good, then proceed to the lower lobe right side, lower lobe left side, and compare. So if you see, this is called as Z pattern of auscultation. Okay, this will be the Z pattern of auscultation.